Greetings and welcome to today's On With Life webinar on neuroplasticity, setting the stage for effective stroke rehabilitation, part of the On With Life stroke webinar series. My name is Dave Clark. I'll be your host for today's event. Our presenter today is Dave Anders, Clinical Director at On With Life. Dave is an Iowa licensed speech-language pathologist who has been practicing in the field of brain injury for 21 years. He's a member of the BIA-IA Board of Directors and received certification as a brain injury specialist trainer through the Brain Injury Association of America in 2012. And he's presented regionally and nationally on a variety of topics related to stroke and acquired brain injury. Dave will be leading us through the rest of today's event. So Dave, over to you.
Thank you, Dave, and welcome to the webinar. This initial webinar in the series, the purpose of this webinar is to really kind of set the stage for the rest of the webinars. And I'll just advance kind of through the slides here. Obviously, I have no disclosures. And this is just a quick view for you at the various webinars that we'll be providing on the topic of stroke throughout 2019. And just a few reminders, there's no cost to attend the webinars. Each webinar is, you do receive one CEU. After you have viewed this webinar, you will receive a questionnaire, a survey, and once you fill out that survey, then you'll receive your CEU. So again, welcome, and look forward to an interesting 6-7 months here of providing stroke-related education for you all. Just a quick kind of run through of what I'm going to be talking about today to kind of set the stage for the rest of these webinars. I'm going to give a little bit of an overview of this interesting word, neuroplasticity. What is it? How does it work? What do we understand about it? How does it apply to stroke rehabilitation? And then I'm going to talk about the principles of neuroplasticity. So there are some rules that we try to follow, some guidelines that we follow in the rehabilitation world in order to make the most out of this concept, and in order to help those of you who are recovering from stroke to make your outcomes as good as they possibly can be. So we're going to review those principles, those basic principles of neuroplasticity. You know, what are we trying to accomplish through stroke rehabilitation? And then I'm going to give some specific intervention-based examples for each of those. Well, not each of those, but for most of those principles. I'm going to end the webinar in talking just a little bit about technology. Technology is kind of one of those big buzzwords that we talk about in the rehabilitation world. And so I'm going to talk a little bit about how you weave technology into stroke rehabilitation, again, to affect better outcomes for individuals who are recovering from stroke. So that's the kind of tentative schedule for the next hour or so. So again, thank you for joining me. All right, so when we talk about improvement or healing after stroke, there are a lot of processes at play, but they can kind of be bundled into two big concepts. And the first is what's called diaskesis. And diaskesis, simply put, is when you have a stroke, when you have injury to the neurological system, you have surrounding cells that aren't necessarily killed or injured, but they are effectively knocked out. So you have this loss of function within a region that's distant to the site of the lesion. This results in reduced metabolic activity, right? Because these cells, they haven't been killed, they haven't necessarily been damaged, but they're not metabolizing correctly, and they're not metabolizing correctly kind of on a temporary basis. They're not using the nutrients that the blood is bringing to them, so they aren't functioning the way they did before the injury. And this happens for a variety of reasons. There's some there's kind of a chemical cascade that occurs as the damaged and cells that are killed, as they go through that process. They release chemicals that sort of knock these peripheral cells out. And this is called diaskesis. So really the first process in healing after stroke is for this diaskesis to resolve, or the resolution of diaskesis. And this is often why we see those larger jumps in function early in the rehabilitation process, right? You see people going from not talking to all of a sudden talking, and you see people going from not being able to stand to now being able to stand. You see these larger jumps because we have these regions of the brain that have been knocked out that are starting to metabolize correctly, and the cells are starting to work correctly. So you have sort of this commensurate increase in function. So that's really, and all of that being said, this process is not well understood in stroke, and how it occurs and when it occurs and how long that process takes. In looking at the research, I've seen that it's the early weeks, and I've heard a couple of months post stroke. So we have some work to do in terms of our understanding of how diaskesis work, or this process of diaskesis resolution works. So once we have those cells back online, and we are left with the dead and damaged cells from the stroke itself, then the primary mechanism of improvement, of progress, of healing after stroke is what's called experience-dependent neuroplasticity. This is the underlying biological pathway to return of function following that stroke-related neuronal injury and death. And experience-dependent neuroplasticity simply means that you can change your brain based on your experience. And so again, we try to structure rehabilitation in ways that change your brain in the best possible ways. So let's kind of dig into this. There are a few mechanisms at play when we talk about neuroplasticity. When I started in rehabilitation over 20 years ago, the primary understanding of how the brain functioned was that the brain was a static structure. In very kind of neuroplasticity, and the concepts of neuroplasticity were sort of in their very early stages of research and very early stages of understanding in terms of the medical model. And so what we believed was that if the brain was damaged, that it stayed damaged, that you could not generate new neurons in particular. And over the years, the better our imaging techniques have gotten, the more we're starting to understand that, in fact, there may be areas of the brain where you can generate new nerve cells. And it's pretty limited, and there is some ongoing research trying to sort of solidify what those specific areas of the brain are. Most recently, we believe that we can increase the production of neurons in the hippocampus, the olfactory bulb, and in the cerebellum. Now, that being said, I just listened to a podcast through the Archives of Physical Medicine and Rehabilitation a few months ago, in which there was a study released that kind of contradicted this idea that neurons could be regenerated in the hippocampus. So there's still some contention about about just how this happens and where this happens and what the mechanisms are. What we know is that you increase the production of new neurons through exercise. Exercise is one of the ways in which this is happened, or the potential for this neurogenesis increases. And we do know that you decrease neuronal volume, particularly in the hippocampus, when you are highly stressed or when you are clinically depressed. And we know that if that depression is addressed, you can increase hippocampal volume in terms of neurons. The second sort of process that plays what's called synaptogenesis. So, and this is simply the creation of new synapses or connections between neurons in the brain. So if you have a nerve cell that has been knocked out or an axon that has been broken and the message is not being moved through that, or the electrical and chemical signals are not being efficiently or effectively moved through that neuron, there is the potential to sort of reroute. The brain sort of reroutes by creating new connections in the surrounding neurons. That's called synaptogenesis. And specifically when we talk about stroke, we talk about axonal growth markers or trophic factors in the contralateral area of the brain. So on the opposite side of the brain in the first week or so post-stroke, and then you see increased expression of growth markers around the lesion itself over the first 3 to 6 months post-stroke. And this, again, is part of the reason why we look at early intervention, and we want to get in and get good rehabilitation early in that stroke, in the process after the stroke. We want to take advantage of this increased growth marker phenomenon and make the most out of that in terms of the rehabilitation process. Gliogenesis. We have these, in addition to neurons in the brain, we have these glial cells, and glial cells surround neurons, hold them in place. They supply nutrients and oxygen to the neurons. They insulate the neurons. There are lots of different kinds of glial cells. They destroy pathogens, remove dead neurons. So they're incredibly important in the structure and the functioning of the brain. And we do know that we can we can grow new glial cells. So that's what gliogenesis means. Angiogenesis just simply means if we're creating new nerve cells, if we're creating new connections between those nerve cells and structures to support those connections, if we're creating new glial cells, we have to keep those structures alive. And you keep those structures alive by supplying them with blood. And so angiogenesis just means the creation of new blood vessels in order to supply those structures. So those are the basic mechanisms of neuroplasticity. I talked a little bit earlier about these growth factors or trophic factors. And this is how scientists, is one of the ways in which we detect increased expression of neuroplasticity within the brain. You'll see increased expression of nerve growth factor, brain-derived neurotrophic factor, and glial-derived neurotrophic factor. So these are some of the sort of indicators that scientists look for as we're studying this field and looking at how the brain works. BDNF, brain-derived neurotrophic factor, is an interesting one in its relationship to exercise. I talked earlier about neurogenesis and exercise. There have been lots of studies that have looked at production of brain-derived neurotrophic factor after exercise. So, as you're thinking about how do I change my brain, whether it's you've had a stroke or you've not had a stroke, exercise is one of the pathways to increasing the potential for changing your brain. This is just a quick slide that looks a little bit at some of our outcomes in our stroke program, and talking specifically about the timing of neuroplasticity. And it's generally believed that these growth factors and the priming of the brain for neuroplastic change following stroke peaks somewhere between 1 and 3 months post-onset. So this is just some data from 175 individuals who have come to On With Life with stroke, and it looks at the timing of change that we have seen in FIM related improvements, which are those sort of functional improvements that we measure as individuals go through our program. And as you can see, the highest percentage of that change comes in those first 60 days or so, with a kind of a steady drop off beyond that. And I think the other important thing to understand about this sort of data is that just because you've passed the peak, that does not necessarily mean that you can no longer change the brain. You may have to work a little bit harder to do it, but neuroplasticity and the potential to change the brain continues long after the injury itself. So there are three basic levels of neuroplasticity. The first is chemical. The most basic is chemical. And you know, when I talk about chemical level neuroplasticity, I tend to think about learning something and forgetting it. So for example, I'm a fly fisherman, and I tried to teach myself back in the early 1990s how to fly fish. And I bought a fly rod and I went out in the front yard and I kind of whipped the line back and forth, and I thought that I had developed that motor plan for how you get a fly line to work or a fly cast to work. And so what I did was I chemically changed my brain in that 45-minute training session so that I could access that motor plan. Well, then I went about a week and thought, okay, it's time to go actually do this on the water. And so I went to a pond and tried to find that motor plan and ended up hooking the back of my hat with the fly. And the fly line ended up in a bird's nest in front of me. Well, what had happened was I'd created chemical neuroplasticity. I had created temporary access to that motor plan. But because I didn't have repeated practice, that the potentiation that I had increased in practicing in the first place was then undone, and it sort of went back to its old pattern. So I couldn't a week later access that motor pattern. We sometimes see this and we often see this in rehabilitation as within the context of a therapy session, the people we serve will pick up a motor plan. They will get what you're trying to help them with, and then they come back the next day and they have lost it. This is likely because we've only affected neuroplasticity at the chemical level, and it's going to require lots and lots of additional repetitions in order to move that level of neuroplasticity from the chemical to the structural level. And when we talk about recovery after stroke or improvement after stroke, really what we're looking for is structural neuroplasticity. And one of the early studies that showed evidence of structural neuroplasticity involved London cab drivers. So they looked at the volume of these individuals' hippocampus. And for those of you who don't know, London, in order to pass the examination to become a cab driver in London, you have to memorize a map of London. And so they measured London cab drivers' hippocampus. The hippocampus is highly involved in memory, and compared that to normal controls. And what they found was that London cab drivers had their hippocampus was larger than a layperson, a non-London cab driver. And so what that shows is that through those cab drivers' experience, they had structurally changed the brain. They had added structure. They increased actual volume of structures in the brain. And this is really what we're targeting in terms of stroke rehabilitation, is we're trying to change the structure of the brain in a way that allows that individual to function at their best. Functional neuroplasticity is really the most complex level. And probably the best example of this is for individuals, for those of us who are born with sight. The occipital lobes of the brain are responsible for interpreting visual input. So the analogy I tend to use is the occipital lobes are kind of like the Kodak station. Back when I was younger, cameras had film, and you would take pictures, and you would take those pictures to the Kodak station, and the Kodak station, people in the Kodak station would develop the film. And that's really kind of what the occipital lobes do for you. Your eyes are like the camera. They take the picture. The information is transported to the occipital lobes, and they develop the film. They connect what you see, what the information brought in through the eyes, to what you understand. And what we have found is that individuals who are born without sight, when you have them read Braille and you look at their brains on fMRI, which shows which part of the brain is working at any given time, as those individuals are reading Braille, so they're using their sensory system, the occipital lobe is actually lighting up. So through learning Braille, that portion of the brain that really was designed to interpret visual information is now associated with sensory information. So you've actually functionally changed the brain. And so these are the 3 levels of neuroplasticity. So what are the rules? How do we make the most of this process? And how do we apply it to the rehabilitation environment? This is really what the rest of this presentation is about. And I guess in a broader sense, this is about what the rest of the webinar series is about, is how do we make the most out of rehabilitation kind of across individual spheres of functioning. And so very quickly, I want to run through the 10 principles of neuroplasticity. So the first one is use it or lose it. And basically what this means is that if you do not use a function, or if you stop using a function, that function and that function's representation in the brain will weaken. The most common, I guess, what I think of most commonly when I think of the concept of use it or lose it is individuals who are hemiparetic, who have lost the ability or have reduced ability to use one of their upper extremities, either their right hand or their left hand. If those individuals rely solely on the use of the functioning hand and do not force use of the affected hand, the brain will learn that, you know what, I don't need to pay attention to this affected side anymore. And you can actually unwire the brain. You can cause additional loss of function in addition to what you've, the damage that has been sustained and the loss of function that has been sustained because of the stroke. So that's this concept of use it or lose it. We often think of that concept in concert with use it and improve it. And that is, if you want something to get better, you have to practice. You have to use that skill. Specificity simply means that you have to skillfully practice the exact tasks that you are targeting. In neurological rehabilitation, we talk a lot about function. How do we change this individual's function? And we talk about specific functions. How do we help them with toileting? How do we help them with rolling in bed? How do we help them with gait? And we need to target, if we want those specific functions to get better, we have to target those specific functions and in the environments in which they occur. It's not enough to work on things that are kind of like the ultimate goal. We need to work on that ultimate goal. So specificity matters. And number 4 is repetition matters. And that's fairly self-evident. We must do a task over and over and over again once we've got it right. in order to actually change the brain. So A, we want to make sure that it's the specific motor pattern, that specific activity, that specific pattern function. We want to make sure that it's accurate first, and then we want high levels of repetition of that accurate function. And we're not talking about 10 repetitions. We're not talking about 100. We're not talking about 1,000. We are talking about thousands and thousands and thousands of repetitions of accurate motor patterns, especially when we talk about motor function. Intensity matters. Basically what this means is that more repetitions in a short period of time are necessary for creating new connections. So we need to have high intensity, high levels of repetition in order to affect change in the brain. Number 6 is timing matters. Basically, neuroplasticity is a process. It's not an event. We have these windows of opportunity, and I've kind of alluded to those earlier in the presentation. We have these windows of opportunity for different skills at different times. We know that in the process of rehabilitation, we want to start people as early as possible in the process. The earlier we start them, the better. And that's because we want to take advantage of this brain's natural priming for neuroplastic change. That being said, research shows that even 5, 10 years post-injury, individuals with aphasia in particular, I'm a speech-language pathologist by background, so I tend to talk about aphasia a lot. People with those language-related challenges, they can change, they can improve with intense practice. Number 7 says salience matters, and I have this one highlighted. I have this one highlighted for a very specific reason, and that is that it is probably as much as any of these others, it is the active ingredient in changing the brain. And what that means in a nutshell is that in order to change the brain, you have to, the activity, the task, the function, it has to be meaningful. It has to engage the individual. It has to be relevant. It has to be important. It has to engage that individual's attentional systems. We have to pay conscious attention to the function we're completing in order to get the brain, to get the most out of the brain's ability to change. And so really what this boils down to is how do we engage the people we work with in their rehabilitation process, and how do we make what we do make sense to that individual. And I'm going to, as we go through the rest of the presentation, I'm going to give some more specific examples of how this happens and ways in which we make this work for individuals. Age matters. So we understand that younger brains tend to change faster, more efficiently than older brains, but also understand that improvement and change are possible at any age. The concept of transference basically means that if we practice one skill, the change that's affected by practicing that skill can, to some degree, transfer to other skills. So if I work on sit-to-stands, working on sit-to-stands from the wheelchair, that can improve sit-to-stands from the toilet. And if I'm doing transfers from wheelchair to bed, that can affect change in transfers from wheelchair to toilet. So while it's best and ideal to work on the specific function, there is some ability for the brain to transfer skill within similar functions. The last one is interference. And interference essentially means that if you learn to do something in a compensatory way, that can actually interfere with relearning it in the correct way. And this concept of interference, sometimes you'll hear neuroplasticity referred to as a two-way street. And I think of it in terms of a three-way street. The one way is, we can affect change in the brain that results in improved function or adaptive function. And sort of the second way is we can change the brain in ways that we lose function. So back up to that number one, that concept of use it or lose it. We can, if we don't practice something, we can unlearn it and we can unwire the brain. So that's kind of the two-way street. Interference, in my mind, that pertains to that three-way street. So we can actually change the brain in ways that make it harder to, we can change the brain in the wrong ways, in ways that make it more difficult to find that functional motor plan, or the correct way to perform a function. So, the things that come to mind, we tend to, in rehabilitation, sometimes use what are called compensatory techniques. So if I teach an individual who's learning to walk, if I teach them a compensatory gait technique, which is sort of a different way of moving their leg, a different motor pattern, an altered motor pattern in order to achieve gait, in order to get them walking. Over time, that altered gait pattern will be solidified in the brain through neuroplasticity. And then later on, when that individual wants to relearn a more normal gait pattern, you have to actually unlearn the wrong one. You have to unlearn the adaptive gait pattern. So that's the three-way street. And so now let's talk a little bit about how do we apply this, and what are some of the challenges that we have in terms of rehabilitation after stroke and these principles. And really the first one sort of comes back to salience. If you remember what I said about salience, this has to do with being able to engage attentional systems, working on things that are important and rewarding and engaging to that individual. Sort of the underlying motivational piece, right? If an individual is motivated to improve and motivated toward a task, they'll be engaged, and that task will be salient, and we'll have greater access to neuroplastic change in the brain. And with stroke in particular, we have a challenge in this area, in that the parts of the brain that are responsible for things like motivation and engagement and awareness of your challenges, right? If I want to change something about me, I have to have some level of awareness that aspect of my function needs to change. And if the part of my brain that allows me to be aware of that challenge has been affected by the stroke, this causes an inherent challenge in the rehabilitation process. And it's one of the reasons why stroke rehabilitation, traumatic brain injury rehabilitation are such challenging aspects in the rehabilitation world, is because of this idea of loss of awareness and damage to the areas of the brain that we traditionally think of as being the parts of the brain that motivate us. What you see on the screen right now is one of the pages from the American Congress of Rehabilitation Medicine's Cognitive Rehabilitation Task Force, who created the Cognitive Rehabilitation Manual. And the reason I have this slide up here is because the very first question, when you think about cognitive rehabilitation, the very first question is that patient aware of their challenges? And If the answer is yes, then we can get to work at cognitive rehabilitation. If the answer is no, we have to facilitate awareness. We have to get them there. They have to be aware that the challenge is there before we can start working on it. And if we start working on it and they're not aware that it's a challenge, we're not helping that individual. That function, that cognitive function, is not going to improve. So really this awareness challenge is sort of the basis for much of what we do, not just in cognitive rehabilitation and stroke rehabilitation, but it's also a physical therapist, an occupational therapist, a therapeutic recreation specialist, a nurse, a physician has to understand the right ways to help people develop awareness of the challenges they have, so that they can then become motivated to address those challenges and to work toward changing those challenges. And I'll just stop here and say, in the background, you're hearing some music, you're hearing some people laughing. We have cocoa and carols at On With Life, and my office happens to sit sort of adjacent to the room where we're doing cocoa and carols. So I apologize for the background noise if that's bothering you. So whom are we talking about? We're talking about individuals. Often we see this in individuals who have damage to the right hemisphere or the parietal region, so you have some domain-specific unawareness, as well as individuals with stroke who've had damage to the frontal systems, where you have true anosognosia, which is loss of awareness of challenges. And it's not always just as simple as the damage to the brain from the injury. The rehabilitation process is challenging in and of itself, and so we have to look at pre-morbid personality traits. How good was this individual at identifying their challenges pre-injury, and what were their coping mechanisms, and are they emotionally prepared to acknowledge their challenges? Sometimes individuals they present as unaware as a defense mechanism rather than as a true function of the injury itself. It's not that I'm not aware that I have these challenges, it's that I'm not emotionally prepared to sort of deal with it at this point. So we at On With Life in particular, we use our clinical counselor who can help with some adjustment to disability work. We have a peer mentor, a gentleman who's had a number of brain injuries who helps with adjustment to disability and helps individuals kind of get to the point emotionally where they can address, start to work on these things. And the other challenge that we often have is that development of a therapeutic alliance. How many chips do you have built up with the people with whom you're working? And this becomes harder and harder the faster individuals move through the medical system after stroke. It takes time to build trust. It takes time to develop the kind of relationship with a person served where you can really start to talk about these tough things and get at the challenges that the stroke has affected. And you really need that therapeutic alliance to address awareness challenges. So how do we address it? And I'm going to start by talking about what we usually do, right? You bring an individual who's had a stroke into the rehabilitation process, and you put them in these different scenarios, whether it's activities of daily living, or it's gait, or it's communication, or it's cognition, and we do a lot of cueing. And we cue them, and we cue them, and we cue them, and we cue them. And then the next day we bring them back, and we do the same tasks, and we cue them again. And eventually they get better. Most of the time, eventually they get better. And the challenge with this is that I've often thought that in all likelihood, it's not the cueing. We are reinforced for all of this cueing we do because we think it helps people get better, when in fact, I think that it's probably often the repetition itself versus the cueing. And the other challenge with this, us cueing people through the process over and over again, is we are thinking for them. And we are sort of holding this awareness thing at bay and tend to be stepping in and cueing when we need to be helping them become aware of the challenges that they're facing. So I don't know that we always are doing, I think sometimes we're doing a disservice to the people we serve because we do so much of this skilled cueing. So what's the evidence say in terms of how do we help these individuals develop awareness so that we can help make rehabilitation more salient and in the same way help their outcomes? One of them is to work on processes that allow them to naturally develop awareness. So the trap that therapists often fall into is that we end up being the ones that tell them they didn't do something well, or tell them they need to improve in a given area. And it becomes this, we develop this adversarial relationship as rehabilitation providers because we're the ones that are telling them what's wrong with them. And this is something I think that therapists struggle with no matter how long you've been in rehabilitation, but it's particularly notable early in a therapist's career, because we come out of school and we believe that it's our job to make sure that the people we serve understand their challenges. And that often is falsely then translated into, I have to force them to be aware. It's my job to make sure that they're aware. And all you're doing by forcing someone to be aware before they're ready or in the wrong ways is you're cashing in chips that you don't have, and you're developing an adversarial relationship. And you're not helping yourself or the people you serve or any of the healthcare professionals that will come in as the individual continues their rehab process. So really, rather than forcing insight, feeling like your responsibility as a therapist is to force insight in the people we serve, your responsibility is to put that individual in situations in which there is a discrepancy between their self-perception and their reality. So, and these kinds of techniques can be used sort of across, whether we're talking about physical functioning, whether we're talking about cognitive functioning, communicative functioning. Essentially what we're going to do is we're going to predict. We're going to ask them to predict, here's the task we're going to do. And it can be anything from a paper and pencil task all the way to an activity of daily living, to shopping at Target. This morning I've got a picture in here later in the webinar of the Target shopping outing that we did with our person served this morning. And so you pick this task and then you ask the individual to predict their performance. How much help do you think you need? How much would you have needed before your stroke? What kinds of help do you need? How many cues do you think you'll require? How much time do you think it will take? And you ask them to make these predictions. And then you work your way through the task. Often we use video, we'll video record, and then you do feedback and sort of self-assessment, facilitate self-assessment as you move through this task, so that you are not the one saying, you know what, you didn't do that well, here's what we need to work on next time. It's, how'd you do? Well, what actually happened? Well, why might that be? And rather than us cueing and stepping in and being this forcing awareness, you're simply asking them to work their way through the process themselves. And then when they do, use accurate self-statements. Well, maybe I didn't do that as well. You jump on that, and that's what you target. So this is just a basic overview of what I just reviewed. This predict, perform procedure. You know, what are we going to do? How much help do you think it's going to take? Let's do assessments throughout. At the end of the task, let's look at what went well, what didn't go so well, and what might we do differently next time. So rather than thinking for the individual, we're teaching them how to self-assess and change their behavior. And this is really a nice evidence-based way to address awareness challenges after stroke. Here's the second one, and this one, we talk about the ideas of specificity, right? We want to work on the specific thing, that specific skill or that specific function that we're targeting, and we want to avoid what's called interference, or we want to avoid changing their brain in a way that is unhelpful. This particular example has to do with memory. And we have a tendency to use a lot of WH questions as we work on memory, right? Who, what, when, where, why, how. This often is the most difficult kind of question for our individuals with stroke to answer. And I'm going to talk a little bit about one of our persons served. And she went through stroke rehabilitation over 30 years ago. And from time to time, she comes back in for a tune-up to the outpatient program. And one of the things that they've worked on over the years is her tendency to say, when you ask her a question, her immediate response is, I don't know. And this immediate I don't know response is the direct result of neuroplasticity and this concept of interference. And here's the challenge, that this is an individual for whom, when you ask that question and she immediately responds with I don't know, if you do a little bit of additional probing, she actually does know the answer to the question. But over the years, she's had so much therapy and she's had so much intervention and she's worked with so many healthcare providers that she has learned, not necessarily explicitly, but implicitly, she's learned that if she says, I don't know, that the answer will come, assistance will come, and this has become functionally a compensatory strategy for her. And it's not like she's doing it purposefully. She just has done it for so long and over so many repetitions, and it's worked so well for her over the years that her brain has become wired in a way that this is her automatic response. So we have a kind of this classic case of interference. And so how do we avoid that in rehabilitation? And really the way that you do that is through what's called errorless learning. And we have an orientation group, for example, and in that orientation group, there are some common things, some common kinds of questions that come up. And the therapists understand that they are never to ask someone a question that they can't answer. So really, errorless learning is all about, if we don't think that that individual is going to be able to answer that question, we're going to give them the answer before they respond. So what we're doing is we are reinforcing the connection to that answer rather than reinforcing a connection to a guess, and especially an incorrect guess. So it's this idea of sort of monitoring the person served, watching for signs of misunderstanding, making sure that we're supporting them and giving them the answers that we're looking for prior to asking for that answer, so that we're creating the correct connections and avoiding interference. If we ask a WH question and either their response is I don't know, or their response is incorrect, all we're doing is strengthening the connection to either the incorrect response or to the I don't know response, which is what happened with the person served I talked about earlier with regard to this. So this screen just represents some of the steps and some of the thought processes as you work with individuals with memory challenges to address, to avoid interference and this learned dependence really on caregivers and providers. All right, we're going to talk about the concepts of use it or lose it. And again, this is the idea that if you don't use a function, that the brain will unwire. You can actually make that function less efficient. And this is a story about one of our persons served who came into our inpatient program. And the physical therapist was working on getting this individual, she'd had a stroke, she had right hemiparesis, so she had some gait challenges related to inability to advance her right leg. And again, I'm a speech pathologist, so I'm probably going to use the incorrect terminology, but one of the functions that the physical therapist was looking at was her ability to raise her toe, to get her toe up. And on admission to the inpatient program, the strength was 1 out of 5. And this was an individual for whom she was heavily monitored by her insurance company, and her insurance company was looking for, and this is kind of a common challenge for individuals with stroke and traumatic brain injury. Insurance companies tend to look at the physical stuff, right? Are they walking more? Are they standing longer? Are they needing reduced assistance for walking? Are they needing reduced assistance for dressing and bathing and all of those sort of physical tasks? And so the physical therapist felt some degree of pressure to get this individual up and get this individual moving. And obviously this challenge that this person served had in getting that toe off was a barrier to gait. And so she immediately ordered a custom ankle foot orthotic, which is what you see in the picture there. And the individual, this solved the problem, the immediate problem, which was how do we get the toe up enough that we can work on gait and get, essentially prove to insurance that this individual is advancing and they're walking farther and they're walking with less assist. So this individual went through their rehabilitation in inpatient and then transferred to outpatient. And on the first day in outpatient, the physical therapist there did the same assessment. So looked at the strength at which this individual could, without the brace, bring her toe up. And what was found was that it had declined from a 1 out of 5 to a 0 out of 5. And that it sort of harkens back to this idea of use it or lose it. We had put a compensatory device in place in order to improve this individual's function that had, in the end, caused her to lose function. And I'm not, I don't want you hearing me say that first physical therapist did the wrong thing. Getting this individual up and getting her walking had a lot of additional benefits. And it allowed her to continue intensive rehabilitation. And there were a lot of functional benefits and outcome-based benefits associated with that. So I'm not saying that first physical therapist did the wrong thing. What I'm saying is we need to think critically about neuroplasticity and the effects of the interventions that we put in place. And this sort of, again, we think of use it or lose it and use it, improve it in concert. And this essentially is a slide that goes through the basic process for constraint-induced movement therapy and constraint-induced aphasia therapy. So this is the idea that we want to make sure that the individual isn't using the unaffected arm at the expense of the affected upper extremity. And with constraint-induced aphasia therapy, we want to make sure that this individual isn't using compensatory communication modalities at the expense of verbal communication. And it's outside the scope of this presentation for me to get terribly into this, but in constraint-induced movement therapy, what you're going to do is constrain the arm, the unaffected side, over an extended period of time and force the individual to use the affected side. Now, there are some very specific criteria in terms of function of the affected side that are required in order for this to be to be an effective intervention for individuals. But it speaks to this idea of, if we don't use it, if I use this good side instead of forcing use of this affected side, the affected side will effectively get worse. And furthermore, it's not going to get better. Constraint-induced aphasia therapy is the same concept. We want to put the individual in situations and give them supports that allow them to use verbal communication as much as possible, so that we can strengthen connection to those verbal responses. This is I'm going to do just a quick video. If you haven't seen this documentary, it's a wonderful, wonderful documentary. It's called Life Support Music. It's a story about a gentleman named Jason Krigler. Jason had an AVM, an arteriovenous malformation, while he was performing on stage, and had a severe hemorrhagic stroke. Ended up with some complications related to infection in the brain, seizure disorder. Was at his most severe was in what's called a disorder of consciousness. So it was at the very severe end of the injury spectrum. And this is a story about his improvement after his stroke, and as well as the family's journey. So I'd highly encourage individuals to watch this. And the clip you're just going to see is a few seconds long, and you're going to hear his father talk, and then you're going to hear his wife talk about sort of his process of relearning to use the guitar.
For a long time after he came home, and after other things seemed to be falling into place, he was moving around more on his own. He was going up to the corner and getting the newspaper in the morning. He was making his own meals. He was doing things on his own. There was a period of time when he did not touch the guitar. Finally, one day, I remember he picked up a guitar and he started working on a simple little pattern of dee-da-da-da-da-da, dee-da-da-da. It was 4 or 5 notes over and over, and I could tell that one note, one finger was not really laying in there the way he wanted it to. And he must have sat there for 45 minutes or an hour just going over this one little pattern, trying to get that right. I'll never forget that.
It was really exciting because you could see that there was music coming through him, and as simple as it was as deep as anything, you know. Being a guitar player for so long and also being a guitar teacher, he knew that you need to play something well before you move on to the next thing. So he was pretty methodical about it. You know, it's almost like he was teaching himself as he would teach someone else.
So that gives you a little bit of a idea about how do you combine this idea of salience with this idea of high levels of repetition. Obviously, that was playing the guitar was something that was highly engaging to him. His attentional systems were fully present. It was important, reinforcing in and of itself, and it sort of naturally came with this opportunity for thousands and thousands and thousands of repetitions. I counted in that clip at one point that there were like 350 repetitions of that plucking of the guitar strings. A really, really good example of a creative way to combine salience and high levels of repetition to induce neuroplasticity. All right, kind of moving into the final, kind of the home stretch as we talk about neuroplasticity. And I'm moving into this topic of technology. And when we talk about technology and rehabilitation, or technology and neuroplasticity, there really are two basic types. You have what's called non-invasive brain stimulation devices, which are really designed to change the potentiation of the nerve cells themselves. And then you have assistive technology, and really sort of, when we talk about assistive tech, we talk about how do we, this is a device that we use to apply those direct rules of neuroplasticity to. So we're working on function itself when we use assistive technology versus non-invasive brain stimulation. What we're doing is we're working at the neuronal level to try to increase the likelihood that change occurs in the brain. So under this category of non-invasive brain stimulation, you have what's called repetitive transcranial magnetic stimulation, or RTMS. And it kind of, in a nutshell, you have electrical current that's run to a copper coil, and that generates a magnetic field. And if that's held over the scalp, that magnetic field kind of induces these perpendicular currents in the tissue below, and depending on sort of the strength with which that magnetic field is charged, you can either increase the potentiation of neurons or decrease the potentiation of neurons. And this is a technique that has been used. It was developed in the late 90s. It's been used somewhat extensively. We have, I believe, a couple of individuals in the Des Moines area who use it in a counseling or psych practice related to depression and anxiety. And it's been thought to be a promising intervention for stroke rehabilitation since the 90s, when it was actually developed. The literature is primarily in upper limb rehabilitation, and that's because the neurons that control the upper extremity are more near the surface of the brain than those for the lower extremity. So the research has been more focused in terms of motor function. It's been more focused on upper extremity. That being said, and I would say that there are also similar challenges for cognitive functions. Because cognitive functions exist more in terms of a network than a specific location, but they also tend to be represented deeper in the brain. That being said, just this year in May, the American Journal of Physical Medicine Rehabilitation had the May issue. There was a study that looked at gait speed and did show some improvement in gait speed for individuals with stroke when TMS is used. It's currently considered experimental. It's not readily used in the field. There's still a lot we don't understand about the mechanism or mechanisms involved in altering neuronal excitability. Lots of variables with it, the shape of the coil, the strength of the current, the frequency, the duration of the stimulation. Still lots and lots of questions about it, but it remains a promising, at least now it's kind of a buzz in the rehabilitation world. in terms of its effect on neuroplasticity. TDCS is I suppose you could call it a similar technology. This is electrical current that runs, it's run between an anode and a cathode. And you can increase excitability by directing current from the anode to the cathode. You can decrease excitability by running current from the cathode to the anode. And, you know, use of this technique is pretty easy. And that's the second image down. There's just these two spots where you place the anode and the cathode, and then you use it in conjunction with your traditional rehabilitative techniques. There's relatively low risk. Despite, you know, there have been multiple studies that show benefits of TDCS, the jury's still out on whether these results really translate into real world benefits. So, you know, there are places out there, and we actually are using TDCS in our outpatient stroke program in conjunction with traditional neurorehabilitation. And it all comes down to, you know, what do we want to accomplish? Do we want to increase excitability, decrease excitability? Where do we want to place based on those? And then do we want to inhibit, or do we want to increase excitability? So to some degree, the jury is still out on TDCS as well. Assistive technology. So we're talking about things like passive assistance, like SABO, which is the third picture on the right. This is a device that uses springs and hinges in order to affect opening of the hand. And then you have what's called active or interactive assistance, and we're starting to see lots of articles and information about exoskeletons. You have upper extremity exoskeletons, which have been around for a number of years and are commercially available in several products. And then you have these exoskeletons that are designed to help with gait. And, you know, lower extremity exoskeletons, again, are newer. They're developing some robust evidence that this is an effective rehabilitation technique for individuals with spinal cord injury. They have received FDA approval for use with stroke, but, you know, based on the current available evidence, there's currently no evidence to indicate the benefit in gait and balance as compared with conventional therapy. That doesn't mean that a few years down the road that evidence won't be there, but at this point we're still pretty early in the research process as we look at exoskeletons to help with gait and balance. As a clinic director, some of the questions that I'm sort of asking myself as we make decisions with regard to the use of these kinds of technologies in the lower extremity exoskeleton in particular, you know, what's the difference in terms of individuals with acute stroke versus chronic stroke? What are the functional indicators that tell me as a clinician that someone would benefit from this intervention? There are a number of different exoskeleton varieties available. So, you know, what's the right one? With hemiparetic stroke, what's the benefit of using a bilateral exoskeleton versus a unilateral one? What's the optimal dose? You know, how many times a week should we be using this for what duration? There are just many of these questions are currently unanswered. And is there, what's the difference in benefit for an exoskeleton versus body weight supported training, you know, which is a more readily available and well-studied kind of intervention to address gait and balance. You know, the one area that I really kind of tugs at me with regard to the use of an exoskeleton has to do with the level of assist, and can I reduce the risk of injury to a therapist by using an exoskeleton to help with some of some of the work that goes along with gait training. It's hard work for those therapists. So if something like this could benefit therapists in terms of their health, that might be a kind of that falls in the plus category. So again, lots of questions out there about these technologies. This is just a quick slide in terms of robotic assist, from upper extremity robotics to lower extremity robotics to computer-based cognitive rehabilitation software. We as clinicians, the aspects of neuroplasticity that we tend to struggle with as human beings, as clinicians, human clinicians, are these ideas of high-level repetition and high-level intensity. And this is just kind of a little bit of the difference in the level of the number of repetitions that you can get with robotic assist versus conventional therapy. Now, there are additional benefits to conventional therapy that you don't get with robotic assist, the most important of which is salience. But obviously there is a place for technology as an adjunct to your conventional or your traditional neurorehabilitative techniques. This is just an example of a few ways in which we use rehabilitation to improve function and enhance neuroplastic change. The two pictures on the left are of FES, functional electrical stimulation, and what you see in the bottom left picture is FES being used in conjunction with the motor plan for kicking. So, can we get more and more accurate repetitions of that motor plan if we include functional electrical stimulation in that rehabilitative session? On the right, you see the use of electrical stimulation for that. You see that individual bring his head up and allows us to provide additional feedback and give opportunity for higher level repetition of that motor plan. And then you see that paired with body supported gait training. And then I have to just do a quick plug for the value of low tech. Oftentimes we find that low tech works much better, or at least as well as high tech. And just a few examples of the ways in which low tech can be utilized. The one on the left, you have a shopping cart, which actually is a great way to get people into an upright, shoulders back, functional position for gait. In the middle, you've got music therapy and the use of guitar. Again, I'm not going to belabor that point with the video of Jason. And on the right is the video from just a shopping outing, Target shopping outing this morning, in which we're using a hiking stick to help with positioning and head positioning. And as you can see, that individual is also being forced to use his affected side to carry his Target bag. So again, this is just sort of the foundation for the rest of the webinars. I hope you've enjoyed it. I hope that it has started you along the process of thinking about how do we maximize these guidelines, this concept of neuroplasticity in as we help those individuals who are going through stroke rehabilitation. Questions?
Thank you, Dave. And yes, it is time now to transition to the Q&A segment of today's webinar. And we have several questions that have been submitted in advance. So Dave, let's see if we can fit in one or two of these before we wrap things up. So to get us started, let's go to a question from Eric. Eric wants to know, do stem cells help with neuroplasticity after stroke?
Okay. I guess first and foremost, I am not currently aware that there is anywhere in the United States that's FDA approved for the use of stem cells for stroke. So there's a whole legal, ethical side of stem cells. My understanding of the field of stem cells is that we're currently attempting to figure out which there are lots of different kinds of stem cells. And so we're trying to, researchers are in the process of figuring out which of those many types of stem cells are going to be best and most effective as we as applied to stroke and injury to the brain. So again, right now, much of that I believe is in animal modeling, and they're looking specifically at movement. So which cells are most appropriate to restore movement? We also, you know, at this point, we're very early in the stem cell process, and it's about, there's some major questions out there, like what's the best way to deliver stem cells to the injured area? How do we turn them on? How do we tell them what to do? How do we tell them to turn off once they've done their, you know, what they're supposed to do? There are several clinical trials underway right now around the country looking at delivery methods in particular, and there are questions out there about how we activate them. How do we get them going? You know, there are some concerns. That question causes me pause to some degree, because there are some concerns in rehabilitation, and valid concerns about individuals spending lots and lots of money to go to Mexico, for example, for to have stem cells implanted, and we just, that's a scary thing, because the regulations around it, we're not sure about safety, and there's lots of risk involved with that. And you know, my hope is, as lots of individuals in the rehabilitation world, is that in a few years that the answer to that question can be yes, that, you know, stem cells, the idea of stem cells in and of themselves, it is all about neuroplasticity. So, other questions?
Well, let's see if we can fit one more in here, Dave. This one's from Valerie. Are there things stroke survivors can do at home to make the most of their improvement?
Well, I would say first and foremost, talk to your therapist. Often as individuals transition to outpatient rehabilitation in particular, those therapists can give you insights into the best ways to carry over what they're working on in therapy to that home setting. So they should be able to give you recommendations specific to you and specific to your, the functions that you're working on. As I noted earlier in the presentation exercise, you know, there's robust information out there on the use of exercise to boost cognitive function, or to delay cognitive decline, as well as to increase BDNF representation in the brain. And then, you know, I guess my general recommendation for all of us, whether you've had an injury to your brain or not, is to challenge yourself, to really be a lifelong learner. One of the, again, whether you've had a stroke or not, a challenge in terms of our ability to continue to improve the function of our brain is this idea of stagnation and doing things the same way over a long period of time. So I would encourage you to challenge yourself, to learn something new, to step outside your comfort zone, you know, to take a risk or two. And in doing that, you activate that engagement, and that your attentional systems come online, and it really, challenging yourself is the way to prevent further decline in terms of your brain's functioning, as well as to improve your brain's functioning.
All right. Well, I think that is just about all the time we have. Thank you so much, Dave Anders. And if you have a question for Dave or like to get in touch, you can reach him using the contact information shown on your screen. Thanks so much for being with us today. That does conclude today's webinar. Have a great day.